Investigating the relationship between access to health insurance and rates of suicides, and is religious service attendance associated with mental health well-being? Currently, there's an epidemic of mental health crises with the historical high suicide rates. While having access to mental health treatment is misaligned through need and most go without. Suicide is now the second leading cause of death for individuals aged 24 to 34 and the 11th leading cause of death in the US overall. The purpose of the study is to examine the relationship between health insurance and suicide rates. Additionally, I investigated if attendance to religious services had an association with the individual's mental health quality. Does having healthcare lower the rate of suicide ideations, and can religious service attendance aid in easing mental health strain? The goal is to analyze the high rates of suicides and bring insight into ongoing research. A study done on 1,622 college students claims every fourth student reported symptoms of depression, and every 10th student having suicidal thoughts. By examining the relationship for comparative measures, I hope to identify an association that provides evidence-based treatment options. Current research says those without health insurance experience suicidal thoughts more frequently than those individuals with private health insurance. Researchers have addressed prioritizing access to healthcare currently impacting millions of Americans. As of 2025, the cost of healthcare has risen to 7.9% annual increase. This is one of the highest rates in over a decade, forcing millions to lose their healthcare. Without knowledge of need or records, how to initiate care is a challenge medical providers are facing. By conducting survey response studies, the data may identify insight, for example, race, widening racial ethnic disparities in suicide attempts, and lowering mental health care utilization for minoritized groups. I chose to focus on how individuals may be utilizing a preferred religious affiliation as a community support system. The sampling method for my explanatory variable, I looked at access to health insurance. For response, I looked at the incidence of suicide ideations, and as a moderator, the attendance to religious services, and from the sample stats below. For database, they had the National Longitudinal Study. The procedure was done for the researchers who collected the 90-minute instrument and did a follow-up with the physical measurements. The methods for my explanatory variable, respondents were asked, which of the following best describes your current health insurance situation? Originally, they were grouped into 13 categories, and then I combined them into the three groups you can see to the right. We had 49.68% had private insurance coverage, and then over 1 in 5 respondents were uninsured. For the response variable, respondents were asked, had they seriously considered committing suicide in the past 12 months with the yes or no format? Had 6.31% reported having suicide ideations, and with a 93.69% reported no. Looking at the combined, we had data show significant evidence to reject that suicide ideations are independent of health insurance access. Our results showed participants without health insurance reported the highest rate of suicide ideations with a 9.8%. The uninsured faced a massive 97% greater risk compared to those with insurance. Data indicates health insurance status is a significant predictor of mental health risk. Then looking at a moderating variable, participants were asked, how often have you attended religious services in the past 12 months? Simplified responses down to 4 categories, and then I just looked at the most extreme measures, the answers with never attends and weekly attends. Looking at the results, we saw the red bar with the high religious attendance and then the low bar, or the blue bar with the low attendance. Being uninsured, even with high religious attendance, is associated with a 36% higher risk of suicide ideations compared to the baseline of having insurance, even with low attendance. The data shows religious attendance is associated with that negative 25% reduction in suicide ideations for the uninsured respondents. And looking at the significance for the never attends, we had a significant evidence to reject that suicide ideations are independent of health insurance access. And then looking at the attends weekly or more, we had no association between insurance and suicide. In conclusion, study confirms a robust association between health insurance access and reduced rates of suicide ideations. The data provides a significant evidence that mental health quality is not independent of insurance status and highlights a critical disparity that demands policy reform. Furthermore, my analysis of religious engagement revealed a vital insight where participation in the religious sector acts as a protective buffer. However, underinsured individuals with high religious attendance remained at a 1.36 plans more likely to report suicide ideations than the privately insured with no attendance. Thank you.